Hi, everyone. Let's make sure you're all in the right place. Today, what you're watching is a 1 hour lecture on infertility and pregnancy loss that is designed for genetic counseling graduate students. So let's get into it with my introduction. If you think this is going to be a boring old grad school lecture, you are wrong because fertility and infertility are fascinating topics, and there is a lot we know, but so much left to be understood. On top of that, I've experienced my own infertility journey that involved multiple miscarriages, and I'll be sharing a little bit about that, as well as stories from my experience as a fertility or assisted reproductive technology genetic counselor. I want to share a little bit more about my history because I've spent my 10-year career as a genetic counselor working in the fertility or preconception or ART space, depending on what you want to label it on a given day. And I think I am one of the only genetic counselors who's worked at what I think of as the three main settings for a fertility genetic counselor: an IVF clinic, a pre implantation genetic testing laboratory or a PGT lab, and a gamete bank. So, let me tell you a little bit more about each of my roles at these locations and what it was like being a genetic counselor there. And to give a little backstory, I think the specialty of fertility genetic counseling is it's amazing. You get to help people build their families and fulfill a dream that many people have had in their mind since they were a young child. And that's certainly the case for me. I was somebody who could not wait to be a mom from my earliest memories in preschool. So it feels very meaningful and fulfilling to get to be just a tiny cog in the wheel of what it takes to build a family if you're using assisted reproductive technology. So, my first role out of grad school was at an IVF clinic called the Colorado Center for Reproductive Medicine. And at that IVF clinic, I helped patients who were pursuing fertility treatment. I reviewed their family history. I helped coordinate genetic testing like carrier screening, karyotype, any other testing that might have been relevant based on their family history. I helped explain their results and also to explain the results on testing they did on their embryos, the pre implantation genetic testing, which I'll talk about more in my next lecture. And I also worked with their donor egg bank, reviewing applicants who wanted to donate their eggs and helping people find a good match, an egg donor that met their criteria. Next, I moved on to iGenomics. iGenomics is a laboratory that specializes in genetic testing related to fertility, so that pre implantation genetic testing. A lot of times people hear the term laboratory genetic counselor and assume that you're not talking to patients or clinicians. That was not the case for my role. I was a clinical genetic counselor employed by a laboratory. So I did spend the bulk of my days speaking with patients and doctors like reproductive endocrinologists, those are IVF doctors, who had questions about our different tests, the different types of PGT or the results, and to help make sense of their results. After that, I moved on to Seattle Sperm Bank, which is a sperm bank in the United States. And at Seattle Sperm Bank, I have, I'd say, three or four main responsibilities. One is reviewing donor applicants. Another is working with recipients who are looking for a donor and helping answer their questions about our donors' carrier screening results and family histories and finding somebody who feels like a suitable pick for them. Three, I help review any updates that come from our donors or from recipients who've used our donors and have received a diagnosis on their donor conceived child and determine what to do with that medical information. And then four, as a lead genetic counselor, I manage our little team of other genetic counselors and our genetic counseling assistant, and I'm just available for questions that others in our company have about genetic testing and genetic protocols. And finally, about 4 years ago or so, I started two YouTube channels just to share my passion about fertility, genetic counseling, and genetic counseling in general. So you could always hear more from me if you check those out. Building out this lecture was a serious challenge for me because I could truly spend an hour on each of the bullets listed on this outline. But I hope you'll leave with a good overview of infertility, what causes it, and how it's often evaluated, as well as pregnancy loss and miscarriages. What are some of the different types, and what are some of the common evaluations? You're going to learn a lot of acronyms. There's a lot of acronyms in fertility and infertility. And hopefully, this is just a good starting place. I will say for me, I in grad school back in 2013 to 2015 only had one 2-hour lecture, I believe, on fertility, infertility, assisted reproductive technology, and that was it. So I've had a lot of on the job learning, and that's okay. Depending on what specialty you might go into as a genetic counselor, you may require a lot of on the job learning to get up to speed, and that's really how I've learned most of what I've come to know today. I want you to think about who you picture when you think of infertility or miscarriage. Pause this video here and think about who are these people? What do they have in common? Who does infertility or miscarriage impact? Or what are your conceptions, your preconceived notions about this? I did the same for myself, and I realized in reflecting back to my childhood, I don't think infertility or miscarriage was discussed with me much at all, but I have a few little like blips in my mind that I recall. Like, I have an aunt who has one child, and I remember her mentioning how she always wished she could have had another child, but not much more than that. My mom, I know she shared with me she had a miscarriage between me and my full brother. But again, no details about what that was like, or was it devastating to her the way that my miscarriages were devastating to me? And what happens after you have a miscarriage? How far along was she? I don't know any of those details. I'm gonna have to go ask her after this. So I want you to think a little bit about that. And I think things have improved. There's a lot more awareness with social media. Oh, we have a guest has hopped up here. There's a lot more awareness with social media about infertility and pregnancy loss and the use of assisted reproductive technology to conceive. But I know I want to do things a little bit differently, and I already am when it comes to raising my children and teaching them about fertility and about access to assisted reproductive technology. And my oldest, who's about 8.5 now, he knows all about sperm, egg, sex, embryos, and fertility. But he also knows about miscarriage, and he knows that having a baby is not something we just get to choose for a lot of us. And there's a lot that goes into it, and a lot of it that's out of our control completely. So I think it's a really important concept to be aware of and to kind of think about how we discuss infertility and who we picture with infertility and what that might mean. So I know recently Kelly Gerardi, this astronaut here, pictured just to the left of the text, she's been coming up on my social media profiles all the time. She recently went through IVF and transferred her only embryo that she created, and unfortunately, it resulted in an early pregnancy loss. And she's been just sharing her story every step along the way, which I think is incredible, and really one of the reasons I started my fertility YouTube channel as well. I'm also watching Friends right now. I'm on season 9. Oh, I'm on season 9, and I'm only about halfway through. And what I'm seeing right now in season 9 are Monica and Chandler trying to conceive and catch Monica's ovulation every single month, and just seeing that cycle. And for a lot of people who are experiencing infertility, it is such a long road. And each month, waiting for ovulation and then trying to conceive and then waiting to take a pregnancy test and then doing it again and again and again is exhausting and can really impact quality of life. So I want you to think a little bit about who you picture with infertility or miscarriage and what you think of those individuals. What do you know of what causes it? A lot of times people have misconceptions that people with infertility maybe are unhealthy, or it mostly impacts older people. And that just, while those things may be true, that really isn't the case for most people. For a lot of people, infertility for them doesn't get an explanation. And miscarriage, oftentimes there's no explanation for why it happened. So, with that, let's dive into just how common is infertility and what are the most common causes of infertility. I want you to take a stab at how many people or what percentage of people worldwide are impacted by infertility, and I'll reveal the answer on the next slide. The World Health Organization reports that about 18% of the adult population, that's roughly 1 in 6 people worldwide, experience infertility. Is that more than you thought? It's a really high number. A few years ago, you would have heard the number 1 in 8 being quoted, but as research continues to expand, it looks like it's an even higher proportion of people than previously thought. And that alone is one of the reasons it is so important to have an awareness of infertility and miscarriage, because even if you practice outside of the specialty of ART or preconception, 1 in 6 of your patients in the cancer specialty or in neurology or wherever you might be have been impacted by infertility. So it's a good specialty to know about regardless of where you end up. Let's talk about what the definition of infertility is. And I'm going to use ASRM, the American Society for Reproductive Medicine's definition of infertility. I was super excited to update this slide because just over a year ago, the ASRM released a new, more inclusive definition of infertility that helped acknowledge so many of the different reasons why patients might need to pursue medical treatment or assisted reproductive technology to build their families. So this new definition expands beyond the older, kind of simpler definition and hopefully has the potential to improve access to care, especially for LGBTQ and single intended parents. There are 3 main bullet points that go into this definition. So essentially, ASRM is defining infertility as a disease or condition or a status characterized by any of these three things. The inability to achieve a successful pregnancy based on the patient's medical, sexual, reproductive history, their age, their physical findings, or any combination of those. The need for medical intervention, like use of donor egg or donor sperm for pregnancy as an individual or with a partner. And then finally, this is part of the more classic or the older definition, in patients who have regular unprotected intercourse and without any known etiology for either partner, suggestive of impaired reproductive ability, evaluation should be initiated at 12 months when the female partner is under 35 years of age and 6 months when the female partner is over 35 years of age. This pie chart breaks down the most common causes of infertility. And what surprises a lot of people is that male factor infertility is almost as common, if not just as common, as female factor infertility. So if you take a look here, you can see that male factor infertility explains 30%, female factor another 30%, and combined 25%. So for 25% of individuals going through infertility diagnoses, there is both male and female factor. About 25% of patients, they never get an answer, even after a thorough evaluation, as to the cause of their infertility. So this can be broken down in a lot of different ways, and you can even break out under the category of male and female fertility what the different diagnoses are there. But I think this is a good summary that really gets to the point that it's pretty common to see both male factor and female factor fertility. So both the egg source and the sperm source need to undergo an evaluation if a couple wants to get to the bottom of why they're experiencing infertility. As a genetic counselor who practices in this space, one of the most common questions I get from my friends, most of whom are of reproductive age and either currently building their family or thinking about building their family if they want one, is when should I seek an infertility evaluation? If I'm trying to conceive and it's not working out, how long do I wait and where do I start? Where do I go? So if a patient history is suggestive of a fertility problem, they should seek an evaluation immediately. There's no need to start trying to conceive if there's already some suggestion that there could be something going differently than typical. So examples of this could be for somebody who's assigned male at birth. Maybe they have something that suggests reduced fertility, such as varicocele, or perhaps they had a vasectomy and then a vasectomy reversal, or they know they've been having unprotected sex for years and they've never conceived with a partner and they've had multiple partners. For somebody who is assigned female at birth, this could be things like irregular periods, a known tubal factor, known endometriosis. For either it could be sexual dysfunction or any individual who has a genetic condition that could predispose them to diminished ovarian reserve or infertility. Those would all be good reasons to go ahead and see a reproductive endocrinologist or a urologist to be evaluated further. For individuals who don't have anything suggestive in their history that there's already a concern, the general guideline is that if somebody who is assigned female at birth, that partner is under the age of 35, they should seek an evaluation after 12 months of trying to conceive. And if the individual is over the age of 35, they should seek an evaluation after 6 months of trying to conceive. So that is the general guideline, but what I tell my friends is that if they are somebody who thinks they might be waiting to conceive a little while, they're just really worried, they should talk about it with their OBGYN right away. Primary care provider for somebody who's assigned male at birth would be totally appropriate as well. But it is just fine to discuss your concerns about fertility with your doctor before you've even tried to conceive. And they can order some testing to give you a baseline idea of how a few things are looking. Now, nobody can predict whether you'll be able to have a baby or whether an individual will struggle to have a baby with any type of testing, but they can run some tests that give you a baseline idea if there's any cause for concern, which might help you or a patient better guide their fertility plans. So what I say is talk about it with an OBGYN or a primary care provider, but then you definitely don't want to go longer than these guidelines that have been put out by ASRM. What's involved in a fertility evaluation? The main goal is that it should be very systematic and cost effective. So somebody who's experienced like a reproductive endocrinologist and evaluating an individual for infertility is going to run the tests that are the least expensive, least invasive, and most likely to identify common factors first, and then work your way down the list to less common and oftentimes more costly tests. And as I alluded to earlier, it is really important that if there is somebody who is assigned male at birth, that partner contributing to the pregnancy, that partner should be evaluated at the same time. I hear the story so frequently that the assigned female at birth partner was evaluated by an OB for years prior to the person contributing the sperm ever being evaluated. And oftentimes those couples come to find out that it was a male factor, it was a sperm factor all along, even though they were only focusing on the assigned female at birth partner. So really important that both partners, if there are two partners in this reproductive relationship, it's really important that both partners are evaluated. Okay, so I want to kind of skim through what an infertility evaluation would look like for the individual who's assigned male at birth and an individual who's assigned female at birth, just to give you a bit of an idea of what all is involved when an individual or a couple goes to see a reproductive endocrinologist. A good portion of a consult, an initial consult with a reproductive endocrinologist, is going to be talking about history. So reproductive history, how long have you been trying to conceive? How many sexual partners have you had? Any STI history? There's going to be social history questions, things like caffeine use, alcohol use, recreational drug use, cigarettes, and so forth. Medical and family history, which would help get to whether there's any inherited or genetic factors that could be at play. And besides a physical exam, for these individuals, really the only and main workup is going to be a semen analysis. And the semen analysis, or assay, is just a lab test that examines a sample of semen under the microscope. Now, semen itself includes three things, essentially. It includes the sperm, the gametes. It includes the fluids that make it possible for the sperm to be deposited by the cervix. And it also includes proteins and vitamins that fuel the sperm. So with an assay or semen analysis, there's a lot that you can find out related to whether an individual may have male factor fertility or male factor infertility. You're going to be able to assess the volume, the amount of semen in the sample, the total count, the number of sperm in a sample, the concentration, so how many sperm are in each milliliter of semen, the motility, percentage of sperm that are moving typically, morphology, the percentage of sperm that are shaped normally, and vitality, the percentage of sperm that are living. And on the right, I just put a quick reference from the World Health Organization, which is the body who determines what's considered normal in semen analysis. The evaluation for someone who is assigned female at birth is going to be fairly similar, and that a reproductive endocrinologist will go through some of the same questions about fertility history, medical history, social history. For individuals who are assigned female at birth, there's more of a workup and a few more questions to be asked. So they would go through, pregnancy history, length of pregnancies, pregnancy outcomes, length of trying to conceive, whether the patient's been monitoring her ovulation. They're going to ask about cycle length. So if you or a patient can bring in an app or a calendar or the paper that they're tracking their cycles on, that can be really helpful, and how they're tracking. Similar to anyone who's assigned male at birth, a physician would be asking about family and personal medical history, whether there's any history of endocrine disorders, any family history of early menopause. Similarly, they would ask same social questions, whether there's been tobacco, alcohol, or drug use, what diet and exercise look like, any supplements or medications that could affect fertility, whether the individual might have any exposures to toxic agents at work or, growing up. And then as far as the workup itself, to get at ovulation and whether the patient is ovulating or not. Typically progesterone, a blood work would be drawn to measure progesterone, and then transvaginal ultrasound could be used to see where in a cycle a patient is. Most of the time, uterine factors will be assessed for pretty early on in a workup, and uterine factors would mean things like a uterus that's shaped differently than typical. And uterine factors can cause an increased risk for miscarriage or difficulty conceiving. To evaluate the uterus, usually that's done either with a transvaginal ultrasound or oftentimes with an HSG or hysterosalpingogram. The HSG is a procedure, and that's what the images on the right here are from. It's a procedure that uses an x-ray, so the patient would lay on a table with an x-ray underneath that table. And it's a very quick procedure. I've had it done myself. A speculum and a cannula is inserted into the cervix, and the uterus is filled with a fluid that includes iodine. That iodine contrasts with the uterus and with the tubes. So you can see this contrast and clearly visualize the uterus and the tubes. So you can see the shape of the uterus, and then you can also see the patency or the openness of the tubes with the HSG. And in the image here on the right, you can see one uterus, the uterus on the left, both of the tubes are open because they can be visualized. And then on the right side, you can see that the second tube is blocked. You can't visualize that tube. And an individual with a blocked tube, of course, they're going to have a hard time getting on that side the mature follicle, the egg, from the ovary to the tube where it would be fertilized by a sperm. So a blocked tube causes reduced fertility, and if both tubes are blocked, significantly reduced fertility. So this is usually the start of assigned female at birth workup. And there are many, many, many more tests that can be done depending on how these results come back and a patient's, more detailed personal history. Now that we've talked about infertility and kind of the basics of an infertility workup, I want to discuss some genetic conditions that can affect fertility. And there are quite a few genetic conditions that can affect fertility, so I tried to stick with some of the most common ones that you definitely want to be aware of and look out for. The first syndrome I want to talk about is Fragile X syndrome. Fragile X syndrome is caused by a loss of function mutation in the FMR1 gene, which is located on the X chromosome. If you don't have your repeat ranges memorized yet, that is something you definitely have to have memorized. And this image here is just a classic image that I remember from genetic counseling school. So individuals with normal Fragile X results will have between 5 to 44 CGG repeats. I look at a lot of carrier screening results, and I would say what's most average is somewhere around like 29 to 33 CGG repeats is what I see most of the time. Someone who has an intermediate, or I oftentimes call it a gray zone result, is 45 to 54. Individuals with that gray zone result, the way I think of it is that in the next generation, they could have a child with a premutation. and the risks associated with being a premutation carrier. But we don't see individuals with that intermediate range having children affected with Fragile X syndrome or with that full mutation range. The next range is the premutation, that's 55 to 200 CGG repeats. Those individuals have a phenotype that is completely distinct from individuals with Fragile X syndrome. And then individuals who have 200 or more repeats, that's essentially the cause of Fragile X syndrome. Fragile X syndrome is one of the most common inherited causes of intellectual disability in males. And other characteristics that go along with Fragile X syndrome, you think about the elongated face, a prominent forehead, prominent protruding ears, macrocephaly. You can also see a few other things like joint differences, hyperflexibility, enlarged testicles. There's definitely a behavioral kind of phenotype with ADHD, speech and language delays. So there's all sorts of characteristics that can go along with Fragile X syndrome. Autism as well. It's one that I didn't mention. But when we think about individuals who are premutation carriers in that 55 to 200 range, they are not affected with Fragile X syndrome. They have, like I said, this distinct phenotype. And two of the things that I want to touch on are Fragile X associated premature ovarian insufficiency and FAXTAS. Those are the two main things that should come to mind when you think about premutation characteristics. Now, there are other clinical traits for premutation carriers, but these are the two that I'd really hone in on. So POI, or premature ovarian insufficiency, that means that you're not creating as many ovarian follicles as typical for someone in your age group. And about 20% of women with premutations have POI, premature ovarian insufficiency. So it doesn't affect everyone with premutations. POI is usually defined by having cycle irregularities that could look like really long cycles, not getting your period for months and months or even years. It is also defined by having an FSH, which is just a lab, a follicular stimulating hormone, of greater than 40. And this is all in women under the age of 40 years. So women with premature ovarian insufficiency, it's not as if they cannot conceive. These women can conceive, and they can even conceive naturally. It's just that they're going to have a significantly reduced chance of conceiving because of the ovarian insufficiency. And then the other thing I always associate with premutation carriers is an increased risk for Fragile X associated tremor and ataxia syndrome, or FAXTAS. Now, if we think about this the other way, among women who have idiopathic, sporadic POI, about 2 to 6% of those women carry the premutation. And then among women who have a family history of POI, 14% of those women end up having the premutation when they're tested for Fragile X. So anytime as a genetic counselor I'm taking a family history and I see a family history of, a lot of people refer to it as early menopause, though that's not quite the same thing as premature ovarian insufficiency. If I see that family history, or if I'm speaking to a young patient who thinks that she has early menopause because of lab work she's done, I definitely want to suggest Fragile X screening to see if the premutation may be the reason. And as far as treatment for individuals who have premutation, the premutation, many individuals decide to undergo IVF with PGTM, pre-implantation genetic testing for a monogenic disease. And I'll talk more about that next week. IVF can also improve their chances of identifying and collecting more eggs. So that's an option. Some people with Fragile X premutations end up using a donor egg potentially, or donor embryo. All right, the next condition I'd like to discuss is monosomy X, which is also known as Turner syndrome and mosaic monosomy X. Monosomy X is one of the most common chromosomal abnormalities identified in individuals who are assigned female at birth. It's thought to be about maybe 1 in 2,500 individuals, females I should say, that are born with that syndrome. And since we're about to be discussing pregnancy loss and miscarriages, I will note that the vast majority of pregnancies that are conceived with monosomy X miscarry. Probably about 98 to 99% of pregnancies with a single X chromosome miscarry. Now, as far as individuals who are living with monosomy X, the vast majority are infertile. Individuals with monosomy X do not spontaneously menstruate. They do not develop secondary sexual characteristics without treatment. And their oocytes essentially die. They undergo apoptosis and disappear by age 2. The phrase that always sticks in my head that I think I remember learning in school is menopause before menarche. So these women, unfortunately, they just don't have oocytes to even undergo an egg retrieval most of the time. Now, some women with 45X, with monosomy X, they have been reported to become pregnant naturally. And the speculation behind this is that those individuals likely have a second cell line that's euploid, that's chromosomally normal with 2 X's in their ovary or ovaries. So individuals with mosaic monosomy X may have the ability to conceive utilizing their own eggs. Individuals who have complete monosomy X or only a monosomy X cell line in their gametes, in their eggs, would be extremely unlikely to be able to conceive utilizing their own eggs. When I've worked with patients who have monosomy X, the vast majority end up carrying pregnancies that are conceived utilizing a donor egg or maybe a donor embryo. One of the other important things to note about monosomy X in pregnancy is that women are at a significantly increased risk for cardiovascular complications. They have an increased risk for aortic dissection and hypertension. So it is very, very important that these individuals have a full preconception evaluation, a cardio assessment, and counseling on the risks associated with those cardiac risks. And some women with Turner syndrome, depending on how their evaluation goes, it is sometimes recommended that they don't carry a pregnancy. So some women with monosomy X use a gestational carrier. All right, next up is Klinefelter syndrome, or 47XXY, and right along with that, mosaic Klinefelter syndrome. So Klinefelter syndrome is really common. It's expected to affect about 1 in 500 to 1 in 1,000 live-born males. Now, in the umbrella category of Klinefelter syndrome, it's thought that probably 80 to 90% of cases of individuals have 47XXY as their karyotype, and the remaining 10 to 20% may have higher grade aneuploidies, like 48XXXY or even 49XXXXY, or mosaic Klinefelter syndrome. And that mosaic Klinefelter syndrome is pretty common. I see that quite a bit. Working in a fertility clinic, I actually have met quite a few men who went their whole life with Klinefelter syndrome, even complete Klinefelter syndrome, and had no idea until they started experiencing infertility and showed up at my clinic for an evaluation. And some of them did have the phenotype that I would expect, but it was not super significant. So things like tall stature, gynecomastia, sparse body hair, androgen deficiency, low testosterone, and azoospermia or oligospermia. Now, these individuals, once you would start naming some of the other factors that can come along with Klinefelter syndrome, some of the behavioral differences, they would sometimes say, some of those things sound familiar, but some really no. And maybe for those men, perhaps they had mosaic Klinefelter syndrome, but it wasn't picked up in the karyotype we ran. Now, for males with Klinefelter syndrome, as I mentioned, they are at an increased risk to have azoospermia, which means there is no sperm in their ejaculate, or oligospermia, which means that they have a low amount of sperm or a low sperm count in their ejaculate. For these individuals, they still can sometimes conceive using their own sperm, using a procedure called TESE, or microscopic testicular sperm extraction. With that procedure, which is visualized here in this picture, sperm is removed directly from the testicular tissue. So this is usually performed by a urologist, And if the urologist can retrieve some sperm, some healthy sperm, those can be used to fertilize eggs with a procedure called ICSI, intracytoplasmic sperm injection, where one sperm cell is put into a single egg cell, and then with IVF. So men with Klinefelter syndrome can sometimes conceive using their own sperm cells, but sometimes that procedure is unsuccessful. They're not able to retrieve any viable sperm, and these individuals end up using a sperm donor. The next condition I'm going to talk about that affects fertility is cystic fibrosis and other CFTR-related disorders. So cystic fibrosis and CFTR-related disorders is a huge umbrella for an extremely variable set of conditions. Essentially, all individuals who have classic cystic fibrosis will have congenital bilateral absence of the vas deferens, or CBAVD. And to understand a little bit more about CBAVD, it's helpful to just have a quick refresher on the male reproductive system. There's kind of three essential parts. There's the testicles, the epididymis, which it's not labeled in this diagram actually, but it's this part, and then the vas deferens. Now, sperm, the reproductive cells, they're developed in the testicles, then they're stored in the epididymis. That's like the series of tubes that sit behind the testicles. The sperm's stored there until it needs to be made available at the time of ejaculations. And then the vas deferens is the long tube that connects the epididymis to the ejaculatory ducts. So if the vas deferens is missing, the sperm are not going to be included in the ejaculate. Now, the interesting thing about this is that individuals with cystic fibrosis, they oftentimes, most of the time, they do have healthy, motile, morphologically typical sperm. It's just that the sperm are not being included in the ejaculate. So there are ways that men with cystic fibrosis can go on to have children using their own sperm. Oftentimes, it's again through procedures to retrieve the sperm. Now, thinking about it again in the other direction, 80% of individuals who are assigned male at birth who are identified to have congenital bilateral absence of the vas deferens, if you sequence them or screen them for cystic fibrosis, they're found to have CFTR mutations. So CFTR mutations or CFTR-related disorders, that is the most common cause of congenital bilateral absence of the vas deferens. When I'm counseling an individual who is confirmed to have CFTR-related disease or even classic cystic fibrosis, of course, it's really important that their egg source is screened for CFTR mutations so that they know if they have an increased risk to have a child affected with CFTR-related disease or cystic fibrosis. And next up is chromosome structural rearrangement. So this would include translocations, both Robertsonian translocations and balanced reciprocal translocations, as well as inversions. It's thought that about 2 to 5% of couples who have recurrent pregnancy loss, that they have a gamete source, either the egg source or the sperm source, with a balanced chromosome rearrangement. So I think of karyotype, the testing that would be done to identify a translocation or an inversion in an individual, to be a relatively low yield test. It's typically only recommended to patients who have recurrent pregnancy loss or patients with unexplained infertility. So if they've done all of the other basic steps of an infertility evaluation and hasn't yielded anything, that's typically when karyotype is recommended. Oftentimes it's completed when patients just aren't able to conceive and they don't have a reason why, so that unexplained infertility. Once a karyotype is completed and it identifies a translocation or an inversion, the really hard thing about counseling these individuals is that they often want numbers. They want to know, okay, well, what's the chances that this causes a miscarriage in my next pregnancy or causes a baby that is affected with birth defects or differences, learning disabilities in my next pregnancy. And because there are so many hundreds and hundreds of different unique translocations and inversions, it is essentially impossible to give these numbers that patients really, really want. So it's one of those things that is just hard to counsel on because you always get the question and there is just not a perfect answer, a well-researched answer for most of the translocations and inversions. Sometimes you can give a little bit of an idea based on research out there if it's one of the more common ones, but it can be tricky. Now, for individuals who are found to carry a translocation or an inversion, there are a few different options. One option is going to be to pursue in vitro fertilization and utilize pre-implantation genetic testing for structural rearrangements. So this would be pre-implantation testing, which again, I'll talk about more next week, but testing that would use a biopsy from the embryo and testing that biopsy to see if there is additional genetic material or lost genetic material, which would be the result or could be the result of a structural change. Other options include natural conception or IUI and prenatal testing to determine if there's any differences in the fetus when prenatal testing like CVS or amnio is available. And then finally, some patients decide to waive that prenatal testing and they want to do postnatal testing instead. The final genetic condition I want to talk about, or genetic difference that can cause an increased risk for fertility problems, is Y chromosome microdeletions, or Y microdeletions. I usually abbreviate them as YCMs, Y chromosome microdeletions. I've got a picture here that shows the Y chromosome and the different regions of it. And I should back up one step here and share that this is one of the most common chromosomal causes of male infertility. Might explain about 5 to 10% of male infertility. So the Y chromosome microdeletion, it's caused by a deletion of one of the AZF regions. And there's 3 regions. There's AZF-A, B, and C. The deletions impair spermatogenesis, and they lead to azospermia or oligospermia. So reduced sperm count or essentially missing, almost absent sperm from the ejaculate. So the Y microdeletion, that AZF region, is so small that this is not something that can be picked up on karyotype. A specific test needs to be ordered, which is just called Y chromosome microdeletion testing. As far as the different regions, the most common deletion that we see is the deletion of the AZFC region. It's also the most mild. So individuals with the AZFC deletion alone, they usually have oligospermia. They still have some sperm in their ejaculate, not completely absent sperm. When you see deletions in A and B, it's typically more severe. Now, importantly, for genetic counseling purposes, male children, all male children of individuals with Y microdeletions, they will inherit the microdeletion. And they will be at risk for similar infertility as their father. So that's something important that I always discuss about when we do pretest counseling for ordering Y microdeletion, and then if results come back and we do indeed see a microdeletion. Now, if there are some sperm that can be collected either with masturbation and sperm analysis or with a procedure like the procedures I've discussed before, these individuals can go on and just use art-assisted reproductive technology to conceive. Let's move on to talking about pregnancy loss. Pregnancy loss is near and dear to my heart because after having my first child at 25, a couple of years after that, my partner and I were ready to add to our family. We were then about 28, and we experienced 5 back-to-back losses. And the cause of those losses was completely unexplained. So despite working at an IVF clinic and a PGT lab and knowing what reproductive endocrinologist I wanted to see to be evaluated and doing all those evaluations, we never got an answer for why. And we experienced 5 first trimester pregnancy losses. So eventually, for some reason I will probably never understand, we were able to have a second child, my daughter, when I was 31, and we don't know. We didn't do anything differently. It just worked that time. And these were all spontaneously conceived pregnancies. So while I've been through an infertility journey, I haven't been through an IVF journey, but a pregnancy loss journey is different in its own. So I want to talk a little bit about how common pregnancy loss is, why it happens, and what the workup or evaluation might be for somebody who has a pregnancy loss or multiple pregnancy losses. Let's begin this section of the talk with a question. What percentage of clinically recognized pregnancies do you think end in loss? A clinically recognized pregnancy, again, is a pregnancy where there is some sort of clinical evidence beyond just an at-home pregnancy test, some sort of clinical evidence that shows that the pregnancy is recognized. So this could be an early ultrasound showing a gestational sac in the uterus. This could also be tissue that's studied after a miscarriage, so tissue from the miscarriage that confirms that there was a pregnancy at one point. What do you think? The answer is about 20%. Is that higher than you expected? It was certainly higher than I expected when I first learned this statistic. Now, when you're looking at data regarding how common miscarriage and pregnancy loss is, you can definitely see variable numbers. You could see numbers ranging from maybe 15 to 30% for the rate of clinically recognized pregnancies resulting in loss. And if you look at statistics for pregnancies lost before they are clinically recognized, so early losses before that maybe 6 or 7 week mark, sometimes you can see statistics as high as 50%. So for whatever reason, with human reproduction, it is not very efficient. A lot of our eggs, sperm, and embryos are not going to go on to result in a typical ongoing pregnancy. The other thing to consider when you're looking at these type of statistics is we know that the rate of chromosome imbalances in egg cells increases with the age of the egg source. So certainly individuals who are older are going to have a higher rate of pregnancy loss than individuals who are younger, just because chromosomal errors or aneuploidies is it makes up a big proportion of the causes of pregnancy loss. This table shows the risk for a miscarriage following a clinically recognized pregnancy based on the age of the egg source. So you can see before the age of 32, for 32 and under for the egg source, the chance for miscarriage is only about 10%. By age 38, the chance for miscarriage is about 20%. By age 40, the chance for miscarriage following a clinically recognized pregnancy is 25%. And while maternal age or age of the egg source is not the only factor that impacts risk for miscarriage, it is the most important, and it is kind of the biggest predictor. Some other factors that can increase the chance for miscarriage is a history of past miscarriages, a history of a stillbirth, gestational diabetes in past pregnancies, preterm deliveries in past pregnancies. But maternal age, like I said, is really the main predictor of the chance for a miscarriage. All right, let's talk some definitions. All of these different types of pregnancy losses were definitely very confusing to me when I first started working in the IVF clinic before I had my own experience with miscarriage, but it's important to have a good understanding of each of these different types of losses so that you can speak with patients well and understand what they're describing. So generally speaking, I think of there being two main different types of losses. Miscarriages are losses that occur before 20 weeks gestation, and stillbirth, which are pregnancy losses that occur after 20 weeks gestation. And in the category of miscarriage, there are quite a few different ways to break that down or describe specific types. One thing you'll hear described that I didn't include on this list is a first trimester or an early pregnancy miscarriage versus a second trimester loss. So that's just going by dating. I think of the first trimester as ending around 13 weeks, so a loss before that would be a first trimester miscarriage. And then let's go through these ones that I've listed. A biochemical pregnancy, it's also often referred to as a chemical pregnancy, is an early pregnancy loss. So this would be a pregnancy loss that occurred before the fetus was even visualized on ultrasound. Oftentimes this is a 4-week, 5-week, maybe a 6-week loss. And it's called biochemical or chemical because HCG was detected. There was a positive HCG result. That could either be from an at-home pregnancy test, or that could be taken in an OB's office or a reproductive endocrinologist's office. So the HCG test was positive, but then shortly after that positive test, a miscarriage started happening, or the HCG started dropping. And biochemical pregnancies are incredibly common. many people have probably had biochemical pregnancies and not even realized it, because it can really just look like you get your period a few days late, or your period is maybe a week late and a bit heavier than typical. So that's a biochemical or chemical pregnancy, and they do indeed count as a miscarriage. Some OBs think of them differently than miscarriages that were clinically observed, especially if the pregnancy test was taken at home, or maybe there was no pregnancy test, just a suspicion that somebody had a chemical pregnancy. Next on the list is a blighted ovum, and the other name for a blighted ovum is an anembryonic pregnancy. I like the term anembryonic pregnancy much better, mostly just because I don't love the term blighted, and I don't think that describes what's happening very well. An anembryonic pregnancy is a pregnancy that starts to develop, the gestational sac forms, but there's no fetal pole inside the sac. So the embryo fails to develop, and that results in a miscarriage. These are very common. They're thought to represent maybe 50% of miscarriages. Okay, next up is ectopic pregnancies. An ectopic pregnancy is when an embryo implants outside of the uterus. The most frequent place for an ectopic pregnancy to occur is in one of the fallopian tubes. Unfortunately, this is not viable, and ectopic pregnancies, they have to be managed either with medication or with surgery, because there is no way that a baby can grow, in a fallopian tube or in the abdominal cavity without stopping to develop itself or causing harm or death to the person who's carrying that pregnancy. So ectopic pregnancy losses. Next is a missed miscarriage, which is also often referred to by providers as missed abortions. This is when the embryo, the pregnancy has died or stopped developing, but there's no physical miscarriage happening. The patient hasn't started bleeding. And in fact, the patient, and I've had some missed miscarriages myself, oftentimes still feels like they're pregnant. They may still be nauseous. They were still having pregnancy hormones from the placenta and still experiencing symptoms very much. But when they go in perhaps for an ultrasound, that's when the ultrasound tech or whoever's performing that ultrasound sees that the embryo is no longer developing. Maybe it's not at the size it should be, or there's no fetal heartbeat detected. It's a missed miscarriage. So I think that covers it for all of the different types of miscarriages and stillbirths I wanted to discuss. And I think that's just helpful and important to know when you're discussing losses with patients. Let's move on to talking about RPL, or recurrent pregnancy loss. Recurrent pregnancy loss is defined as 2 or more clinically recognized pregnancies that ended in a loss. And again, a clinically recognized pregnancy is a pregnancy where there's ultrasound evidence that the pregnancy was developing at one point, or a clinically recognized pregnancy could be confirmed when someone has a miscarriage and the tissue or the fetus from that loss confirms that there was a pregnancy there. Recurrent pregnancy loss impacts a relatively small proportion of conceiving people. About 5% of conceiving people experience 2 consecutive losses, and about 1% of conceiving people experience 3 or more consecutive losses. So this is the standard recurrent pregnancy loss workup. A few of the categories of things that you would probably have assessed are uterine anomalies. So if your uterus has an abnormal shape, that can lead to reduced risk for conceiving, or reduced chance of conceiving, and an increased risk for miscarriage. Under the hormone category, it's important to look for a few different things. Increased levels of prolactin or hyperprolactinemia. That's an endocrine disorder that can cause reduced fertility, can cause irregular ovulation. It's just a blood test to look for that. Thyroid function is important. Again, just a blood test to measure some thyroid levels, because untreated hypo or hyperthyroidism can cause an increased risk for miscarriage as well as other complications during pregnancy. Hemoglobin A1C, that's to determine whether you might have diabetes, and diabetes can cause an increased risk for pregnancy loss if it's poorly controlled. Under the immune category, there's some blood work you can do to test for antiphospholipid antibody syndrome, which is a treatable autoimmune disease. And then under the genetic category, karyotypes. Karyotypes on the egg source and sperm source are typically recommended because if a chromosome rearrangement is identified, well then perhaps you could do PGT SR and identify embryos that have a balanced form of chromosomes to transfer. And as I had mentioned earlier, only about 50% of individuals who complete an extensive workup get an explanation for why. And I should say this isn't exhaustive, but in the literature I provided to you, you can see a more exhaustive list of all of the workup. You also want the things that I mentioned in the infertility workup, like semen analysis and medical history, that type of stuff as well. While we're on the topic of pregnancy losses, the next thing I want to discuss is POC testing, or products of conception testing. This is a really important test to be pretty knowledgeable about if you work in the field of ART or preconception genetic counseling, because products of conception testing can give individuals or patients some information about what might be the best way to continue forward on building their family, and also some closure for why a pregnancy loss occurred. Products of conception is testing the tissue from a miscarriage to determine whether the loss is chromosomally normal or chromosomally abnormal. And depending on the technology you use, you'll find out which chromosome was imbalanced. Was there an extra copy, a missing copy, and was it inherited from the egg source or the sperm source? And there are generally two different types of technology that are used for POC, and one is certainly not as good as the other. The more antiquated technology is doing a chromosome analysis, a karyotype on the tissue from the miscarriage. The problem with this tech is that if you have a piece of tissue and you're running a chromosome analysis and the results come back 46XX, typical female, we do not know whether that tissue came from the person carrying the pregnancy from their endometrial lining, or whether that tissue was indeed from the pregnancy, from that fetus. When a person has an early loss, at 6, 7, 8 weeks, the amount of tissue is small and they may not necessarily see a small fetus. Therefore, it can be really hard to determine, just based on the looks of that tissue, whether it is maternal or whether it is fetal in origin. So with basic chromosome analysis, you cannot rule out maternal cell contamination, which means that a 46XX result is not really that informative. It could be maternal tissue or fetal tissue. Now, the superior technology is called SNP-based microarray, and with this technology, you use a sample of DNA from the person carrying the pregnancy. It could be saliva or blood, and that's sent in along with the miscarriage tissue. And they're able to use SNPs and compare the SNPs in the carrier's DNA to the SNPs in the sample that they receive that they're assuming is fetal. And if the sample shows 46 chromosomes and 2 X's, they can determine whether it matches the carrier SNPs or whether there's a combination of other SNPs. So it is confirmed that it's fetal. So that SNP-based microarray testing is the testing that I always recommend to patients who want to test their tissue from a loss. I want to just talk about some of the most common POC results that we see. About 50% of first trimester miscarriages are found to be chromosomally abnormal, and I've definitely seen literature that suggests it might be even higher in individuals with infertility, closer to 60 to 65%. And that, of course, is going to be higher as the age of the egg source increases. The most common aneuploidies that we see are trisomy 16, trisomy 22 and 21, and monosomy X. And then there's also the possibility that you could see a structural rearrangement, an unbalanced structural rearrangement that suggests that there is a parental chromosome rearrangement. You can follow up on that by getting karyotypes on the egg source and the sperm source, so it can help identify that as well. I'm going to show a couple of POC results here. One of them is mine. I just wanted to show what this maternal cell contamination result looks like. On one of my losses, I had a NORA miscarriage testing, which uses the microarray chromosome, which uses microarray with SNPs. And here you can see that the result was maternal cell contamination. So the sample that was sent in was not fetal tissue, it was my own tissue. And they were able to use my DNA sample to confirm that. Alternatively, you could get normal results. normal female results where they can use SNPs to rule out maternal cell contamination. And I just don't happen to have on hand an abnormal result, but if there's an abnormal result, they can determine the parent of origin. So whether that chromosome imbalance was inherited from the egg source or sperm source. Okay, in these last 5 minutes, I just want to talk a little bit about preconception genetic counseling and some of the details of genetic counseling in this setting. The main goals of preconception genetic counseling or preconception counseling are identifying risk factors and providing education, counseling, and initiation of appropriate interventions or services prior to pregnancy. The patients that we see in the preconception or ART setting may be patients who have no known risk factors. So for example, working at Seattle Sperm Bank, I talk to patients every day who are planning to use a sperm donor. A lot of my patients might be single moms by choice or same-sex female couples, and they oftentimes have no known risk factors. Maybe they haven't had a fertility evaluation, as they don't think that there's anything they may be at an increased risk for, and it might be something I uncover when I'm speaking with them. In IVF clinics, a lot of times I'm talking to patients about age-related risks due to advanced maternal age, sometimes advanced paternal age. It's common to talk to patients with recurrent pregnancy loss or miscarriage history to go over their products of conception results with them. Of course, you're talking to patients with infertility, patients who have a concerning personal or family history due to a genetic condition that they may have or that may run in their family. And what I'm excited for is next week during our discussion, we'll walk through some examples of some common preconception appointments and what those can look like. Some of the counseling aspects that are unique to this setting and you want to have resources prepared for is infertility and miscarriage is all-consuming. It affects every aspect of your life and it makes life less enjoyable. So it is really common for individuals who are going through losses or infertility to be experiencing depression or anxiety or just generally having a hard time because it is such a consuming aspect of life. So it's important to be able and willing to explore patient support systems. Some patients choose not to discuss their losses or their infertility struggles, their treatment with anyone. Some people are very limited to one friend or one family member. So I oftentimes will ask patients, oh, are you sharing, the fact that you're going through fertility treatment with any of your family or friends? And kind of perform a little bit of an assessment to see what type of support they're getting and to explore whether they might reach out to a friend or family who would be able to offer some social support. One of the things I talk about a lot with patients is that different people cope differently. Oftentimes patients will compare themselves to someone else and say, well, my husband he's already over it, or I know somebody who went through this and they just weren't struggling like me. So just explaining that it looks different for everyone and that's okay, that's normal. Very important is the ability to review options for ongoing support. So as a genetic counselor, I'm not going to be able to be there for that patient and talk with them every week or every month. So a lot of patients do need some support beyond what I can offer, what a friend or family can offer. My favorite support recommendation is for an individual to find a therapist who has a focus on fertility treatment or infertility or pregnancy loss. Those therapists, oftentimes they've been through it themselves and they can be invaluable resources. There's websites like resolve.org that host online support groups that are free of charge. That can be nice to check out, and some even have in-person support groups depending on how big of a city you live in. There's a Recurrent Pregnancy Loss Association, which hosts free online support groups. Not everyone loves recommending these, but I've found a lot of comfort in a Facebook group that I'm in for recurrent miscarriages, and there are Facebook groups for every single niche of infertility and losses. So that can be a nice place to find other people who are going through the same thing as a patient. And then a lot of fertility clinics, larger fertility clinics, offer their own in-person support group. Many have therapists that are in-house. I oftentimes discuss the freedom that patients should have the freedom to skip baby showers, to skip family and holiday gatherings, and anything else that's triggering for them as they're going through fertility treatment. So being able to discuss that and help patients release some of the guilt they might feel for skipping those types of things, and helping them release shame they might feel for fertility that they didn't ask for and they didn't cause. The other good thing to be aware of is to have an openness to discuss the patient's losses. If they've had later term losses or stillbirths, to discuss the baby's name, to look at pictures of the baby. A lot of patients who've experienced losses feel as if, especially stillbirths or second trimester losses, they feel as if those children of theirs are forgotten. So to have someone who can ask a little bit about the loss, ask, did you name the baby? What was his or her name? And be there and hold space for that baby with them can be really meaningful and impactful. And then lastly, I just wanted to go over some of the different types of genetic tests that you counsel on as a preconception genetic counselor. And I tried to arrange these from most commonly discussed to least commonly. So expanded carrier screening, I mean, that's something I'm talking about constantly at all of the settings I've been in. Karyotype, discussed very frequently in terms of looking for parental structural changes. Molecular testing for a patient-specific diagnosis. So oftentimes, a patient might come to us because they have a personal diagnosis of hearing loss due to a specific gene mutation. And we'll be exploring what the recurrence risk is because they're coming to me to do IVF and they want to understand better what the risk is. We'll also oftentimes talk about molecular testing based on family history. So maybe a patient comes in with a very concerning family history of cancer that looks suggestive of a hereditary cancer syndrome. We might order hereditary cancer testing in that case. There may be a history that looks concerning for a completely different syndrome, not cancer related, like Marfan's, and we could order that. We also do targeted variant testing. Perhaps if a sibling of a patient has a known variant in a specific gene that puts them at risk, we might do that targeted variant testing. We also might do gene sequencing. Maybe one partner is affected with a genetic condition and the other partner is not comfortable with just doing carrier screening. They want the full sequencing. Products of conception testing I discuss pretty frequently. And then there are some other kind of offshoot things like primary ciliary dyskinesia panels, or it's becoming more common that there are panels of genes that might be causes of infertility. So you deal with actually quite a bit of genetic testing if you're a genetic counselor who works in the preconception setting. And we'll talk about this more during the discussion. I'm going to bring in some kind of sample reports and we'll go through what some sessions can look like. All right, I'm going to put up my references here and I'm looking forward to seeing you all live. Bye, guys.